It's just kind of, I'm kind of like surprised we're at module 4 already. That feels good. I'm excited for us. Okay. We're going to talk through multiple stress responses. I wanted to check in with folks before I start pulling up some slides and just check in with people about how was your module, the questions that came up, how was your self-study portion of this material? Overall okay, or like difficult, or how did it feel?
It was it was good for me to really look at the state dependent functioning and kind of realize. I think that Erica mentioned this in our last session, that freeze doesn't necessarily only belong to dissociation, that's a part of that hyper dysregulation too. That's a part of that alarm and even adaptive functioning. So that was really good. And then the functional IQ is kind of cool and fun to talk with my clients about this week or this last month. Like,
Yeah.
you're literally getting dumber the more aroused you become. Isn't that interesting? And then they all good laugh.
It is really practical information. And once you learn to spot the trait or the state, it's easier to figure out where people are. It becomes really helpful in clinical work, right? Okay. Well, let's move into some material, and this can be, I don't have a whole lot today. I thought we could just really focus on the basics so that we can really be able to talk things through as people have questions. So I can't see folks, so Angie and Erica, I'll rely on you to catch the chat and if there's any questions or anything.
You got it.
Okay, so we'll talk about multiple stress responses. So you would have seen this in your videos and different slides that you've come across. At this point, you're going to feel like some things are starting to feel familiar, and you'll look at a slide and think, I think I've seen that somewhere, because it starts kind of not repeating, but looking similar across lots of different pieces. So we've got, we're going to talk specifically today about hyperarousal and dissociative continuums. And let's see if I can get my mouse. Nope, that's not going to work. Okay, so on the hyperarousal continuum, when people are calm, over in the left-hand side, if you look down at the bottom, the mental state, when people are calm, they're at rest, hopefully not aroused, right? We can dream about what vacation you want to take this summer, or what you want life to look like later in the year. You can daydream, you can plan and create. As your day gets a little bit more stressful, you might be a little bit more alert, right? And so if you tend to operate on a hyperarousal, kind of an outward stress response, you're going to be a little bit more vigilant. If you tend to run on the dissociative continuum, you might be a little bit more avoidant. So you might not want to think about the hard meeting you have later that day, or you might put off making a phone call. And then as your day, if your day continues to be stressful and your arousal state is going up, as you get more stressed, we look at where the red arrow is. If you are on the more outwardly facing, that hyperarousal continuum, it looks more outwardly facing, you might become a little bit more resistant. Or if you're on the dissociative continuum, you might look more compliant. So for kids, this might be, as you're trying to rush out the door to get to school on time, if you have a kid who's a little bit more hyper aroused, then they might be more resistant to putting on their shoes. And there might be an argument about whether or not you need to wear a coat that day, or whether it's too cold to wear shorts, or any of those things. If you have a super compliant kid, that can tell you something, where if you're looking at it thinking, this child is super compliant, it might be that it's a dissociative response. As the day goes on, as people get more stressed, or as events are happening maybe in the classroom, if you look in the column for fear, kids who are super stressed on the hyperarousal continuum are going to start looking more defiant, whereas kids on the dissociative continuum are going to look more like dissociation, and we're going to talk about that more, of what that would really look like. And then if truly there is a threat, and people are not okay, they're either going to become aggressive, or on the dissociative continuum, you might faint. In babies, you might see them going to sleep rather than fainting. So those are kind of interesting things to think about. Any questions on that before I move forward? Okay. Okay, so if we think about dissociation versus arousal, and this is using wide stereotypes, right? This doesn't mean that it's prescriptive in the way that only females can be dissociative, or only males can be aggressive, or show an outward response of stress. This is just kind of some general noticings, and I think it's how culture shapes our roles in society, and lots of messages that we receive throughout our lifetime, depending on your gender, or expectations placed on you by society. So females tend to lean more heavily towards dissociation, whereas males tend to have more, it's more socially accepted for them to fight, right? Even play wrestling and that kind of thing is more socially approved. For young children, often there's not a chance to advocate for yourself or speak up, whether that's just due to development, or because you are really young and you require people to take care of you all the time. And so you are more dependent on people meeting your needs. And when that doesn't happen, you have to self-soothe, which if you don't do that well, can lead to dissociation. Whereas older children really do have an ability to run away. They have the ability to throw items, or, look more, they have the ability to speak up for themselves. So you can get a little bit more of that, like verbal defiance, that kind of thing. If you have experienced a lot of pain or torture or hurt or harm to your body, more often people are going to dissociate because you can't get away. Whereas if you've witnessed a lot of violence happening to other people, I think a normal response is to see that happening. It's not happening directly to your body, so you don't have to check out internally. You can, sorry, something's happening outside my house. That's very loud. You can witness violence happening towards other people, and you may be more prone to reproduce that in your own stress response. And then if you have been trapped, if you're kind of like we were saying, if you've had harm happening to your body, you can't get away, and so internally you have to shut down in order to survive that. Whereas on the arousal continuum, you can have a more active role in defending yourself and keeping yourself safe. So let me come off the share screen section for a second and check in with people. Does that slide make sense? What comes to mind as you look at that? I see some heads nodding, so I think it's making sense to people. How do you see that playing out with the clients you're working with?
This actually came up with one of my clients because she seems to oscillate between the two depending on what's going on. Because she would dissociate a lot during sessions. I'll be asking a question, she would appear calm, and then she'll just zone out for a few minutes. I wouldn't be able to get her back I'll just kind of wait for her to check back in. And other times, like at home, I would hear that she would be stealing and she would be very defiant. So she seems to oscillate between the two. So a lot of times, like I would love to see that it's more clear cut and straightforward, but oftentimes it could just be a mixture of the two, which makes it more confusing in my brain.
Okay. I'm glad you shared that. We're going to look at a slide that kind of shows that. I think that's very accurate.
Yeah, I agree. I experience that a lot with my clients. That it's not like maybe one's more predominant, of course, but that there's a lot of bouncing because of complex trauma. Sometimes it worked to fight, sometimes it didn't work. And so the brain's trying to figure out which one to use, you know?
Right. Yeah, I think different stress response systems are going to serve you well at different points of stress, right? Yeah. Thanks for sharing that. Okay, let me go back to our screen.
I'd like to add something in there too, Angela. We often in clinic, parents or caregivers will bring a child in and say, the child does super well at school, but then when they get home, they're acting out all over the place. So there's probably something to that and where the child is landing on that continuum based upon how safe they feel in their environment. So they probably do that movement like Delbert was talking about based on the situation, who's in charge, how much power they have, all those different contextual factors that come into effect.
Mm-hmm. Yeah, I mean, if the goal is survival, if you don't have a lot of power, serves really well to dissociate, right? To kind of check out. Whereas if there is a chance of you having power, then it serves you well to have a more outwardly facing stress response system, more on this arousal continuum where you could fight and defend yourself, right? And I think, we know people are really wonderful at reading nonverbal cues if they've grown up in an environment that's not safe. And so people figure this out really fast about what's going to serve them best in the moment. It becomes pretty reflexive over time. Okay. My screen is locked. I'm not sure how to get out of that. Hold on 1 second. My screen completely locked up. Let's see.
Ours is stuck on the dissociative arousal balance slide. Is that where everybody else is at?
Yes.
Well, my screen completely locked and I can't exit out of, there we go. Okay.
Technology.
I know, right? Gotta love it some days. Okay, let's try this again. Okay, so if we're looking at dissociation, we've got some nice cheat hints here for you, but talk to me about, how do you understand dissociation? When you hear that, what does that look like clinically? What's your understanding of that? What does that mean for clients?
Možda neki bijeg od stvarnosti, povlačenje, stvaranje nekog sopstvenog svijeta, kao neki bijeg od stvarnosti.
Very much. That's a great way to describe it. Early in my career, I thought of dissociation as being something more like that would happen during a schizophrenic break. And really, that's not what Dr. Perry's talking about. It's not that kind of dissociation. It's like you were saying, it's a way to deal with what's going on. It's kind of a checking out internally. It's attending to the inner world more so than the outer world.
I see my clients show dissociation in lots of different ways. So like the client I just mentioned, she just kind of seems to zone out in the distance and gets really, really quiet. So the external world seems to like, the noise gets really, really quiet, but her internal world is pretty loud. Other clients, they daydream a lot. So it's like a lot of numbing and they just go in their head and they have this whole story that goes on. Another client, I described it like if you're lagging in a video game, you may not really notice the environment, but you're acutely aware of your character and what they're doing. For some of my teens who love playing video games.
Like that. I like what you said about the inner world just being really a lot louder. I think that makes a lot of sense.
And I was in a phone call yesterday and we talked about disassociation being very functional. So everybody disassociates, and kind of when you read a book, you disassociate, right? And so that would be functional disassociation. And people who escape to their inner world to get away from reality and you can't get them back, that would be dysfunctional, right? And so everybody uses disassociation to block out that noise and focus on the internal world. And I was like, that really helps me make sense, because sometimes you see that continuum and you think disassociation means like you're going down, but sometimes you can be functional and just block out stuff. Like people in the sports world will call it like a runner's high, where you're like in the zone. Everything else is blocked out and you're just like in there, right? Sometimes I'm at work and next thing I know, 3 hours have gone by because I've done, 2 metrics and I've done a bunch of work. And so it's just like, boom. So it's another way of thinking about it. It's functional.
Andrew, would you say that when there's that dissociation check on the brain map, because cognitive is high, is that an example of somebody who's been able to use dissociation well enough to like do good in school to have that cognitive stuff online? Because I do have some clients that I've noticed struggle with dissociation and the cognitive isn't there fully because they're completely dissociated in school and not on that high. But in watching one of the last videos, Dr. Perry talks about that common dissociation check where cognitive over here is higher. Is that an example of somebody who's actually gotten good at using it and has compartmentalized school and cognitive things?
So that's a pretty packed question, Delbert, right? For our simple presentation.
Sorry.
But I mean, I don't want to, Angela, you can answer that if you want, but all I'm thinking about is therapy sometimes is disassociation, where you have to turn inward and think about yourself, right? And so if you can do that on what I would say a surface level, then that would be using functional disassociation. When we see the disassociation check, that's when it's become dysfunctional usually, and people have not developed those yet, because remember the rating for those is 12 is fully functional, like we're able to use this skill or this skill is developed. So typically that's what challenges individuals is they go into this disassociation and they can't get out of it, or they can't really be functional in that mode. But I mean, that's a great question. I think the metric does that, is it opens up those opportunities for you to talk and say, hey, you're really good at being able to focus on your schoolwork and get that done. But when you get stressed out, that skill to kind of hone in and have that tunnel vision is gone.
Mm-hmm.
Would you say, Andrew, that's more like when there's also the freeze component in with it? So a person has their foot on both the gas and the brake at the same time. So nothing is functioning well, versus when you're not in the freeze mode and you're dissociated, you can still kind of stay cognizant of what's going on internally.
Exactly.
I think anything in excess is harmful, right? Like My kid loves pizza, and if she could have pizza for dinner every night, that would be amazing for her in her world. But that would not be healthy, right? And so you want people to be able to dissociate some, to get some tasks done, to have enough reflective capacity to figure out what's going on internally so that they can be have mindsight about others. You know, some of these things are helpful, but when they're in excess to the point that that's the only way that you can deal with stress, or that you are only comfortable in your inner world and not in your external world, when there's no integration between the two, or when you can't leave that dissociative state and reintegrate back into the classroom or the conversation you're having with someone, I think that's where it becomes harmful over time.
And that balance is where I see parents struggling a little bit, like, wait, you're telling me that video games can be good, but only maybe for 30 minutes at a time? What? And then we got to do something else and regulate. And there's that balance, right? Because most games today, if you're not in it for a good couple of hours, you're not submerged inside of what you're doing, you know?
Right. Yep. But like Andrew was saying, there is a functional element to this, right? Like at times you just have to get homework done, or your work life needs your attention. And so blocking out other distractions and just focusing in is really helpful. But if you disappear from the world and you're only attending to the inner world all of the time, then that's where it's not helpful. Okay, so let's talk through hopeless and helpless. So I think I didn't pull as many slides on the arousal continuum because I think that is a little bit more obvious to people. Those people that have really high stress response systems on the arousal continuum are kind of what you get in the referral, right? You get the referral for the kiddo who is flipping tables at school and who, you know, is being aggressive. Like those things are really easy to spot. We tend to understand that pretty well. So I wanted to focus a little bit more on the dissociative because I think it's a piece that, you know, gets not as well understood. It's a little bit more nuanced, and those are not the referrals that come in, right? Teachers don't send in referrals for a girl in the classroom who does all of her homework on time all of the time, right? Teachers love those kids. So that doesn't come in as much. So I wanted to spend some time looking at that. When we look at the dissociative continuum, one of the things that we see is that hopelessness and helplessness kind of come into play here. That if there's a lot of trauma, I'm going to go back in slides for a second. On this dissociation side, there's towards the bottom, we talked about if you're being harmed or if it's inescapable, that takes away your ability to help yourself, to develop self-helping skills, right? It's a learned helplessness where it's been reinforced over time that you're not powerful enough to help yourself. And so your brain starts learning, like, I don't know how to help myself, and I'm not developing the skills I need to help myself and to have the initiative to problem solve and to you know, move forward. There's a defeat reaction. So before anything ever starts, you might hear people say, you know, what's the purpose? I'm not going to win anyway, right? Or I'm not going to be successful. It becomes almost reactive to just feel defeated. There's a surrender response that happens with a really high rate of dissociation. And then capitulation, where there's some summary around, this isn't going to work, right? So those are just things I think that are helpful. These often get come into play around depression, right? And sometimes I feel like anxiety is easier to work with because there's actually energy behind anxiety, whereas depression, these pieces are hard because the body and the brain has learned not to move forward, right? Okay. My screen is blocking some of my words. Let's see if I can get this to move. There we go. Okay, so some of the responses that we see to trauma and stress and distress is the heterogeneity of response patterns. So meaning I can have a stress response system. Say, for example, Delbert and I go through the exact same experience. Sorry, Delbert, I'm going to pull you in as an example. We go through the exact same experience. We're both in an environment where a really stressful or traumatic thing happened. But the way that we intake that trauma and the way that our brain pulls that together is very different, right? So given my history and my genetic makeup and my experiences, I may have really adaptive changes in my cognition from that trauma. Whereas Delbert, you might have more adaptive changes in your affect or your behavior. Neuropsychology, physiology will be one for some people, but for others, it'll be in their physiology, right? And the brain, the whole point of stress is to survive it, right? Like that's the brain's goal at the end of all of this. And so you're going to have adaptive changes that help you survive that stress and trauma based on the other experiences you've had early in your life. So if you've had really attuned and responsive caregiving throughout your lifetime. And I live in Oklahoma. We have a ton of tornadoes all the time. If you have a one single event, like a tornado, we do have this weird thing where Oklahomans like go out and look at the tornado for some reason. We just think that that's fascinating, and we have no danger awareness around there's a tornado coming like right at you. You can see it with your eyeballs, and we still stand out there and look at it. We're weird that way. That's probably an adaptive change in our cognition to realize that's a danger sign we don't pay attention to. Other people might have it in their physiology where you might develop illnesses, and Dr. Gabor Mate, he talks about that a lot, that stress, when it's not attuned to well, it impacts your health, right? And we know about that from ACEs and all that kind of stuff. It might be adaptive changes in your behavior. Some people are really good about, they hear a gunshot and they're going to duck, right? Because their brain has figured out how to do that fast. Whereas other people, that might not be how their brain has wired that information. So it's important to think about when you're creating your recommendations for your clients as you're doing these metrics, to know that everyone's going to input information just a little bit differently, and there's no one kind of recipe that you can apply to all clients. You want to really be looking at what are the adaptive changes within their genetic makeup and how their brain has encoded those experiences, and what is their response pattern, how is it developed based on what they've been through. And so the recommendations you make will be a little bit different for each person. So for one kiddo, you know, even if you have two different kids who are scoring in high attention to like sensory motor issues or sensory integration, you might have one kiddo that soccer works really well, but then another kid where rocking is the better option. And so you want to take the nuances of the client and how they have encoded their information and how their brain has adaptively adapted to their trauma. Let's see here. I'm going to pause here and just leave room for some questions, if there are any, about around this. Does that make sense to people? I can't see anybody, so someone will have to just come off mute.
Yes, it does.
Yes.
Okay, good deal.
I think this, sorry. I think this is like probably a good example of maybe not getting too super specific in your recommendations, so that it gives the parents room to explore what different sensory integration is doing. Is it regulating up or is it regulating down? And probably a good reason for us to follow up in 6 months to see what adaptive functioning is happening, what's helping the most.
Right. I think that if you're doing reports as kind of a one-off, like, I've never met you, you come in, we do a report together, and then I send you on your way. I think there's risk in that. And Dr. Perry's talked about, like, that's really not the point of this. This is a clinical tool to help inform your treatment. And I think that's where it's nice because you can say to parents, like, let's try this, like you're saying, Delbert, and let's see if they gear up or gear down based on this intervention. And then if we're wrong, that's okay, right? Like we still know that they're struggling with sensory integration. And so soccer is not going to be the thing for them. Instead, it might be wearing a backpack with a couple of heavy books in it, or it might be a weighted blanket or rocking, or, different things like that. And you have to try sometimes and fail in order to figure out what's going on internally. Okay, so let's look at, I love this. I love these next three charts we're going to look at. So dissociative regulation would be, this is your window of tolerance, right? Between the red line and the white line, the dotted lines across the screen. There's your external world up at the top, and internal world down towards the bottom. And we expect people to operate within a range, right? And so you've got the typical range here would be the green line, the green wave, where someone might lean a little more towards the external alert system, where maybe you're alerted to what's going on, but then you figure out the world is safe. And so you kind of calm back down, and you're going to have this wave pattern where you're partly in the external world, partly in the internal world, partly in the external world, partly in the internal world. And that's healthy. That's integration, right, between the two. If you have someone who relies more heavily on the dissociative regulation, they may alert slightly, gear up slightly toward the external, but they're going to sink really deep more into the internal world. And then they'll come back out into more of a typical range, and then they're going to dip back down into that internal world. And what we see is they've gone so far down into that internal world, it's kind of past the norm. And so this is where you're going to see cognitive gaps. This is where they're going to be really sensitized, where it's normal for them to exist in the internal world a little bit more heavily than what we would want them to. So that's what it would look like. Someone's attention span would look like if they are more on the dissociative line. Whereas someone who might be a little bit more on the predominant in the hyperarousal continuum, they're probably, this is where, this becomes easier to see, right? Because it's very external. And so they're not coming into the typical range as often. They're kind of living in the higher end of that window. And, they might not be really coming into their internal world at all, much at all. And this is where, again, this part's not healthy either, because you do want to have some awareness and reflective capacity, right? Like that's part of healthy functioning. And this person is not having those. They're very outwardly based, hyper vigilant, hyper aroused, and they're going to be missing what's going on inside of their body, which is an important piece of information. And then, like you guys were talking about, there's that mixed pattern that we do see in clients often, where sometimes they're on the way top of the window, and then other times they're way down deep into the window. And it's kind of feels like it's all over the place. It's important, I think, to be able to figure out if someone is operating purely in the hyperarousal continuum, the outwardly facing continuum, or if they're this mixed pattern. And you want to be able to recognize that. Okay. So I'm going to stop sharing and just check in with people. How does that information sit with you? How does that make, what comes to mind about your clients as you think about those things?
I
Sorry.
actually started thinking about some of our typicals, the ones that we practice on, and how folks who have learned to manage that continuum, maybe they are drawn to certain professions even. So firefighters or nurses are kind of drawn to, put themselves into those situations. They'll run towards that stuff, where others who might be more dissociative, I'm thinking maybe even therapists, where we're more reflective of that and how certain situations are impacting people. So it helps me to kind of better understand the atypical presentation or history, to also think about our neurotypical folks who have found out how to use that continuum to their advantage and in their professional life.
Yeah. It's an interesting idea, Angie, about professions. I would be curious about that.
And the guy that we're going to talk about in my presentation here in the second part is he's kind of not the stereotypical presentation that Angela kind of showed us, right? Because he's a male, but also dissociates more frequently. And I think part of what our role has to be is helping explain to families, what that looks like and why they do those things that they do, right? And so because he dissociates, exactly like Andrew was saying, he loves to read. Like, reading is his thing, right? And like, raise your hand if you feel like reading is a bad coping skill or a bad way to use your time, right? Typically not, but his parents have been taking away his books as a punishment, right? And then guess what he's doing in turn? He starts destroying things in his room. Well, now which one would you pick? Reading the book or him picking at his windowsill because he has nothing else to do, right? He's dissociating in a different way, right? He's just kind of like zoning out. And I think sometimes it's hard for parents to use that scientific lens and looking at that and thinking, okay, maybe I did create that environment for that to happen, right? Maybe he is using a coping skill that he's had in the past, needed in the past, found positive ways to use it. And when we take those away, then he goes back to using it in a maladaptive way, right? And figuring out, okay, like, let me examine myself. I think that that's a lot of times one of our biggest challenges is how do we support parents and not blame parents, but help them understand their child and how to help their child outside of the therapy room, right? Because love all the work that you all do, but you're not going to be able to change the kid completely by yourself, right? We need that help. So I think that's something to be thinking about as well, and how we present that.
I had a question. I know just seeing the charts about that mixed presentation of both arousal and dissociation. I know sometimes I've worked with kiddos who will have a really aggressive outburst and then say, I blacked out, or I don't even remember how I got to that point, and things like that. And I think oftentimes, a common reaction for a caregiver could be, well, you're just trying to avoid accountability, or, that piece, and kind of distinguishing it, because I think there are truly kids that may be a little bit more in control of an aggressive outburst, but just some advice for how to distinguish between a kiddo who maybe is kind of experiencing both in that mixed presentation at the same time, and thoughts on how to educate, in our setting, it's professional house parents working with them on approaches to a kiddo who has that mixed presentation. That was a big question I had with this topic. Thank you.
That's a good question. I have a response, but I also would be curious to hear from my co-trainers. My response would be, what's the harm in believing them that they don't remember, right? I mean, at the end of the day, they lost control, whether they remember it or not. I think one of the biggest pieces when you hear Dr. Perry talk about working with parents is helping them to be attuned to the state of the child. And at the end of the day, if someone lost control to the point that they do remember or don't remember, they still lost control. And if the goal is regulation, honing in on whether or not they remember is just a power struggle that no one will ever win. So I do get that there's a piece around like accountability and that kind of thing, but I would wonder if maybe it's more helpful to focus on attuning to the state of stress in someone before they get there and working on some preventative pieces. That would kind of be my thought, but I definitely want to hear from Erica, Andrew, and Angie and Sarah if I don't think she's here today.
Yeah, no, that's so funny, Angela, that's where you went, because that's exactly where my mind went, is that with our teens especially, I feel like everybody throws out manipulative, right? Like they're just being manipulative, da 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 da. And I think very much the same thing, that ultimately we want to promote positive relationships with our kids, right? And so if we work on that relationship enough, I would like to think that the child will get to the point where they can be honest, whether or not they are being in that moment. And then my other thought was exactly kind of what you said too, is that it would be more beneficial to focus on, okay, maybe you don't remember, right? But we have to figure out, right, what are the triggers? How's your body cues feeling up to that point? Because it's not going to be that instantaneous, right? So how can we take those steps to notice what our body is telling us before, and then tie that to an intervention on some grounding, so that we're not getting to that point of where we're not safe and where we're not keeping other people safe. But yeah, I mean, I think it is tricky, and we want to be able to explain every phenomenon to mankind, right? But that's a big ask, because the brain is so complex and it is hard to explain every single little thing. But
So I'm going to try to draw a picture. Dr. Perry does have a video where he talks about this very thing. And, you got I use 0 to 10. We can use calm, alert, alarm, fear, terror, right? So 0 is no arousal continuum. 10 is terrorized. And so we got these kids, and they've got, let me see if I can do a dot here. Well, I'm just going to draw. So he's got, a situation, and then he feels a little bit stressed, and then he feels a little bit more stress, and he's going up this continuum. Well, sometimes what happens is we have kids who have a disassociative continuum going on at the exact same time. And so what will happen is, as they go up the arousal continuum, right, they're going up and down and up and down. They're getting angry, and then they're calming down, and they're getting angry. At the exact same time, there's this disassociative continuum where they're going up and they're turning inward, and then they're coming back down, and then they're turning inward, and then they're coming back down. And so what happens is they start turning inward, and there's a term called blind rage, where people are actively going through survival techniques, but they don't know what's going on. If you think about individuals who are in a car accident, and they crawled out of this twisted metal, and they're like, what happened? And they're like, I don't remember a thing. That's an example of disassociation, where your mind shuts off, but your survival skills are still going. And so blind rage is very true, and those survival skills are very true. Or sometimes, and Dr. Perry does a better job because he uses a 3D model. So if you take this and you kind of turn it like a cube, one side will be arousal continuum, and the other side is the disassociative. And so you can see how he's kind of like going up in the arousal and then over to the continuum. And can you guys see my picture? Okay. So it's not very clean to think about and to talk about, but can you be at a 7 on the arousal continuum and a 7 on the dissociative continuum at the same time? Certainly, right? Because disassociation can be functional where you turn inward. Like you're running from the bear catches up to you, and you go into the fetal position, and then you go back to running, right? And so how, like Erica said, how to best describe that may not be the point of therapy sessions. The parents need to know there's something going on in there. How that child interprets it and shares it may be their way of expressing it. It may not make sense to us. So let's try to meet them where they're at and find out what their need is, as opposed to like calling them a liar or saying they're being manipulative, right? But, the more that you participate in NM the more you find these little like nuggets of Dr. Perry and other people talking about stuff like that. And you're like, oh, that makes a lot of sense. I have a client who doesn't eat, and not eating is disassociative, right? You know, and so, oh, that makes sense. You know, because you have to ignore your hunger symptoms, and that's turning on your disassociative.
I think it's interesting when you say that, because we had a student, he doesn't do it now, but about 4 years ago, you could clearly see when he dissociated, and it was a kind of turning inward. He almost lost all eye contact, almost all awareness of what was going on, and would kind of melt into the floor. But this, in the same instance, when he got to a certain point or a certain level, and a lot of times it would go into like a restraint or something for safety concerns, the dissociation was still there, but I think staff had a hard time understanding that because he was so physical. And then after the fact, when we would process, he would say, but I had a good day, didn't I? I had a good day. And he had no recollection of, you know, hitting, spitting, kicking staff, because he was dissociating. But I think a lot of staff were like, well, he's aware, he's moving. Like if you're dissociating, you're just blank. And that's not always the case. And then we have another student currently that his trauma trigger is a female student that we have. And so he dissociates and his heart rate goes down, and you can see him dissociate, but then he has an arousal within like 20 minutes after being exposed to this other female student in crisis. So we've seen that now as a pattern, but in the beginning we were like, what, you know, what's going on? So it's just interesting when you talk about, and you showed that graph there.
Yeah, I like thinking of zombies when their eyes roll into the back of their head and they're walking around. That's disassociative arousal, right? So if you ever see a zombie, just know they're disassociating, but run away because they might be aggressive too.
Yeah, and I totally hear the point of, you know, for the actual therapeutic work with the kiddo, you know, that it doesn't, you know, exploring whether or not they truly, you know, had that blackout experience doesn't make sense. But I do think, you know, Erica, as you're describing like staff reactions to that, and as we work with caregivers, I think it really makes a difference too in explaining how those two things can happen at once. Otherwise, caregivers might start taking it personally if it's like, but I have such a good relationship with this kid and they still kind of attacked me. You know what I mean? Kind of helping them to stay in a place where they can keep connection, as opposed to, gosh, I thought I was getting through to this kid and he attacked me. And so they start getting standoffish and not giving the relational pieces the kids need. So I think just from an education standpoint for either staff or caregivers or, you know, what have you, I think that helps to be able to educate on that a bit.
Well, ultimately, if the goal is safety, you know, states become traits. And so we don't want kids to be at level 10 of dissociation or arousal, you know, very often, because states become traits. And we don't want the brain to fire and wire around that and become super comfortable in that phase. We want it there for crisis and when there really is a bear, you know, tracking you down or something like that. But we want caregivers to become attuned to reading kids' states and talk, you know, being able to spot where they are and then helping kids walk it back, you know, as much as possible. Ilda, I saw that you came off mute.
Mislim da je jako važno u radu sa djecom da prepoznamo kad je disocijacija ok do neke granice i kada nije, kada na neki način šteti djetetu, jer nekako u radu sa djecom više obraćamo pažnju na djecu koja ispoljavaju agresivna ponašanja, koja su sklona nasilju ili tome slično, a nekako manje obraćamo pažnju na djecu koja su povučena, izolovana, nekako to više prepisujemo njihovim ličnim osobinama. I kada se desi da takvo dijete ispolji neku negativnu reakciju, onda smo u fazonu šoka, šta bi tom djetetu, šta se desilo, otkud sad to, tako da je negdje važno da prepoznamo kad je ta disocijacija ok, a kada baš i nije. Nekako lakše prepoznamo kada su osobe, ne znam, uznemirene, kada burno reaguju, nekako više očekujemo to od njih i to je na neki način kao normalnije.
Ultimately, we just want caregivers to be attuned so that they can help kids regulate, right? That would be the goal. So that if kids are dipping too far one way or the other, they can return to a state of calm and that they can learn how to get there on their own eventually. I think that's kind of the point of co-regulation, right? You can't do it on your own, so you have your caregiver help you do it. And then as that happens hundreds of thousands of times throughout your lifetime with a safe caregiver, then you develop that ability to do it on your own. And that's where self-regulation that's how that unfolds. Okay, let's take a break. It is 5 till the hour, so why don't we come back at the top of the hour and then we'll have a case presentation. Okay, take a break. We'll see you in a bit.
Hopefully we're all drifting back in. Mouse is moving slowly. Okay, here we go. Okay, can everybody see my abstract on the screen? Cool. All right, let's see how many people do we have on here. Alrighty, perfect. Well, we'll go ahead and hop in. So, I know Andrew sent this out, I think yesterday, so hopefully you got a chance to look over it. If not, I will give kind of a brief, quick overview of T's abstract real quickly. So, I did an initial metric on T, gosh, probably about a year ago, and was not able to do a 6-month, and so then we're about a year out now, and was able to follow up with him. And so when I did his initial metric, he was in residential, okay? And T is someone that has been adopted. He was born, I believe, 6 weeks early. Mom and dad were not very stable financially. Mom was 18 years old, and just really was struggling, had some cognitive delays. T was born with marijuana in his system. And so DFS got involved pretty much immediately. Mom was living with paternal grandma. However, after 6 weeks, he was still not growing. He was missing doctor's appointments and not getting all the nutrition that he needed. And then at 8 months, so he was in one placement, and then at 8 months, he was moved to his second placement in foster care, who would then go on to adopt him. He was still very much so pretty frail at that point in time, behind on kind of several milestones, stated that he was still in an infant car seat whenever he was 8. The other thing that was really odd, and this is something that you can learn from me or my mistakes, is that as I'm presenting this to you guys, I was like, man, why didn't I follow up on that? Right? It's really odd, because at this point in time, it said that he, from the first metric, that he was kind of allergic to everything. So when he was a baby, the adoptive family would have to take him to the local hospital nearly every time they wanted to introduce him to some sort of food, just to see if he would have an allergic reaction or not. And so I can imagine that that's not a normal environment, right? That's not something normal that you would go through. But somehow his allergies doesn't seem to be an issue anymore. So that's a first big question mark that I'm not sure what happened there. So anyways, he was adopted at 18 months. Throughout his life, he did not do well in sort of structured settings, daycares, school. Behaviorally was an issue for him, but he had several other kind of emergency placements in his home. And then, let's see, when eventually he got the family adopted a sibling set of 3. And whenever T was in 2nd grade, there was a 12-year-old that came to stay with them on and off for several years that would kind of cover him up with a blanket and hit on him, physically assault him in that way. He's been diagnosed with ADHD, started therapy as early as kindergarten. A big thing for T is that he the family did not inform him that he was adopted until he was 12 years old, and that was pushed by a therapist. Several therapists, they tried to engage with several different therapists, and they would not do treatment unless the family agreed to tell T that he was adopted. And so from the family's perspective, all behaviors significantly escalated after he was told that he was adopted. And so I think they sort of blame the treatment team for that. He started then sort of having auditory hallucinations. He was very physically violent, doing very dangerous things, leaving razor blades sort of laying around in his room, hid a knife in his room as well, had several hospitalizations, and then was in a residential unit throughout COVID, in which time he had very few visits with his parents. His parents found it difficult to do seeing as they had 3 other children at home. And I believe they also, so 4 other children at home, because they then had a biological child that's a baby. The other thing of significance was that when T was younger, adoptive dad became very, very ill for several months and thought that they might lose him. And so there was a 6-week portion of time where T lived with adoptive mom's mom while mom was tending to dad. Okay, so in residential, had very few visits with adoptive parents. Not this past Christmas, but the Christmas before that, so December 2021, he did have an overnight or a stay with his parents, in which they returned him home a day early because he was stealing and lying, and I believe he threw some rocks at mom's new car. Okay, so relationships are not strong. He doesn't have very many attachments whatsoever. And a few months ago, he was returned home with only having that one overnight. Okay. And the residential was closing. Apparently there was a, discharge plan kind of suggested, and the parents were not able to kind of follow through with that. As far as visiting more often and those types of things. So parents very, very unhappy with the way that behaviors have been since he's been home. And quite frankly, have said not nice things to T in front of him, right? Dad has said that he's sort of done, doesn't want to be a part of it. And so it's a struggle. Okay. We will move on to the brain map, and then we'll kind of open it up for suggestion or thoughts or questions. And then I also want to share my recommendations that I came up with for him. So this is T's developmental history chart. It's kind of a little bit more wonky than a lot of my developmental histories, because you're seeing now again that adverse experiences are more significant than his relational health, right? And this constitutes that he is now finally going back to school full day. So hopefully he can gain some friendships there, but he's not in any sports. He doesn't get along well with his siblings. He doesn't have good relationships with his parents. Most of the time he is in his room, grounded for lying, stealing, those types of things. And so he just doesn't have really much engagement with anyone. Developmental risk, he's back in the high risk range, right? Because he is back in his home placement. And if you just looked at that at face value, you would think, oh, that should be great, right? But because of the lack of follow through with the discharge plan, he's not seeing a therapist at all right now. And parents are currently discussing whether or not they need to put him in another placement already. There's a lot of instability there, as you can imagine. for a 15-year-old. So this is the biggest problem right here, right? Is that he is very much so in the impoverished range for current relational health. And so as we've learned and continue to put significant importance on, is that when we don't have that relational health as a buffer, these adverse experiences impact us all the more, right? So I don't know if you all have seen a follow-up metric before or not, but it's nice that you get to see this. These are his numbers from time 1. Okay, so he had a brain score, a total brain score of 232.
Can you
versus-
zoom in can you zoom in on that a little bit? It
Let
says-
me just do that for you, Andrew. Just once.
I got bad eyes. I've gotten old.
Okay, I got all this other stuff in the way from Zoom, so I gotta. Okay, let's see. Let's close that.
Perfect.
Okay.
Can I ask a quick question?
Yes.
When you're doing the follow-up, do you have to be the person that does the original one to have it both like that? Because I have a student that I did a second map on, but I was not the clinician that did the first one. But but it would be cool to see them side by side like that.
Yeah, that is a good question. I don't know, Andrew. I've never had a referral. I think, oh, Angela's raising her hand. I feel like maybe she has the answer for you.
You do, because
Yeah.
the report lives within your
That makes
portal,
sense. Yeah.
your account, and there's not a way to send it to someone else's account.
So
Yeah.
I'll tell you, with us as a site here, and I'll turn my screen back on. I'm a site administrator. And so if Erica did a map on T and then I wanted to send it to Delbert, I can assign Delbert the map. But if you're an individual and you want to assign it from one person to the next, then I don't know that that's a possibility unless you get with Emily Perry and with the NM. And so in all honesty, you can just do a second map and compare the first printout to the second printout. It's just nice to have them side by side.
Yeah, that's what I did. But I just like the way that looks. So
It's more
was just
convenient,
curious.
right?
Yeah, yeah.
And as far
Pretty
as
ex-
fidelity,
Mhm.
as long as both of you have fidelity scores, then they can be considered accurate, because you should know where they started. Hopefully you have the original.
Yeah, I do. Yeah, thanks.
Yeah. Good question. Okay, so initial score 232, follow-up 259. Okay, and so this also shows how kind of flexible this can be a little bit, because I got reports from mom both times, right? And so mom was in a much better place with T on time 1 versus where she was in time 2. And so I had to be very much more aware of just kind of her temperature, if you will, or her stress level, I think, and her arousal, quite frankly, with T, that I made sure that I was taking her word sort of so if you will, right? And much more observed on my interaction with T, put more weight on that, and also discussions just with his team, because I know how frustrated mom was that T did not come back home from residential to meet what her expectations were. So you can see that there is growth there, right? His brainstem is a little bit more secure. The cognitive areas look a little bit better as well. And all of this is on medication, right? But then are still some areas that did not show as much growth. So, and I don't have this whole chart memorized either. Andrew probably does, because he's a show off. No, I'm just kidding. Just kidding, Andrew. Relationships, right? Relationships maintained the same. And if not, I would say probably a little bit worse, because I think the feeling is that relationship will not get any better. And T will be able to tell you that he doesn't feel any sense of connection with anyone at home. Okay, and so he has the same peer map because he's still within that same age range. So you can see there's still a significant gap between quote unquote normal or neurotypical, right, and where he is, but also that there has been growth, but also some slide backs, right? And so I think that that's important to see. And I don't think that because there has been some areas in which his development has gone, attunement has gone down, that necessarily means that one was wrong. I think that that's just coming from his situation being so drastically different. Now he's back at home versus in a much more structured setting. And just the whole energy situation is different that he is in at this point versus even 10 months ago, right? So then cortical modulation ratio, you can also see that there is some growth there. I feel like that was a real positive to show his team that he used to be sort of in the infancy state, and now he's moved up into this early childhood. And so his cortical modulation ratio is much more emerging. That self-regulation and executive functioning is much more emerging than what it had been prior. Even if it doesn't seem to feel like maybe, 0.17 points or whatever that math is, I'll leave that to someone else, may not look significant, but it is, right? And you can see that this curve sort of mimics the rate and growth that we would want up here. So it really is something to celebrate. And then we have time one compared with current, and then age typical and mature, right? And so again, you see all the growth that's made except for which column, right? Relational, which I think also really goes to speak to next steps, right? And recommendations and where we should focus that on. Because this is some significant growth for sure. Any thoughts or questions as we're looking over his brain map before I get into the recommendation part?
Yeah, I've got a couple quick questions. Is there any dissociation?
Yeah. So this is the kiddo that we talked about, or that I mentioned earlier, that really likes to read. He really likes to do puzzles. He really likes to play video games. He likes to build things. He likes to take things apart and put them back together. Sometimes he doesn't do that as successfully, but and then when those things are taken away, then he becomes destructive. And so I very much so tie this dissociation back to one, probably all the times he was in the hospital, right? From the allergies and those types of things, as well as probably from being born early, the neglect, right? And then in his adoptive home, the abuse from the older foster child, right? So lots of different ways in which he needed to have that dissociation whenever he was younger, and still lots of ways that we see that today.
Okay, because it looks like there's that check on this second one, right? Right here.
Mm-hmm.
I don't see it as much on that first one, but we got
Yeah, sure.
But I'm just baffled by the diagnosis of bipolar 2 disorder.
Yeah, and very interesting. I think just the differences in which he presents and sort of the current problems that are associated versus the problems that were associated through the first time, right? So the first time that I did a metric on him, it was rightfully so, the auditory hallucinations, the unsafe behaviors, the aggressiveness, you know, still some of the inappropriate, he says very inappropriate sexual comments. So that has transferred over, but we're not having any of the auditory hallucinations. We're not having any of the aggressive behaviors. However, the relationship is still very much worsened, right? And so that is a conversation that I had to kind of have with the parents on what was your expectation for him whenever he came out of residential, right? What were you expecting? And so whenever mom states that, well, the expectation is that he's not lying about everything and he's not stealing from his siblings all of the time. You know, at minimum, that's what I was sort of expecting, is what she said, sort of word for word. And those are all the things he's still doing, right? Versus what I was hoping to hear was, well, he's more stable, right? And his medication management has been handled and he's safe now. And so I think that just again goes to show that mom needs so much more support, right? Parents need so much more support, because all she can focus on is the struggles that she's going through right now, versus the really significant growth that he has had. Anyone else? So I'm going to share my recommendations. And I put these together a little bit differently than what I normally would have when we get to the relational part of things, just because I knew sort of the place that mom and dad were. So I really wanted to break it down for them even a little bit more, in hopes to not make things so overwhelming and really give them the step-by-steps that I was wanting them to do. Okay. So because I don't think we've gone over recommendations at all, really, so far, I just kind of want to explain the format, right? So it's broken down by the 4 areas that we get in our metrics. So the sensory integration, self-regulation, relational, and then cognitive. And then the rating that we see in our metric. Well, let me go. I got too much stuff open. Sorry, guys. Right. So sensory integration, I know, is therapeutic. Okay. And I oftentimes also refer to, okay, therapeutic is 65 to 85. His percentage is at 82, right? So he's really on that very much so high end of that cutoff. Okay. And then for the action, that's what I want them to do. And the notes is sort of the why. Why is that important? Why do we need them to do that? What benefit is that going to give them? Okay. So sensory integration, again, we've talked about how this is different for everyone, and there is no sort of cookie cutter thing. I leave this little quote on all of my recommendations just because I think it's so important for families and teams to recognize that we don't want to assign a kiddo to do something every single day, possibly multiple times a day, if they're not going to enjoy it, right? We don't want this to feel like homework. We don't want this to be something that is a fight to do, because that's kind of counterproductive for us, right? So we want these to be things that are enjoyable. All right, so weighted blanket, again, even more so because his intimacy barrier, right, is probably going to be on the much more adverse side, right? He's not getting a lot of hugs. He's not getting a lot of high fives. There's not a lot of room for that. And so this way is a safe way for him to kind of get some of that sensory input, that deep touch, as well as appropriate oral stimulation and other fidgets. And I have in here at least I used to. Serious conversations with parents, right? So dad is from a military background. And so he's very much more so that old school, look me in the eye whenever I'm talking to you type vibe. And so I left that in there as a way to say, sometimes kids need something else to do with their hands or with their bodies to help them focus on what you're saying without it feeling like such a power differential, right? And then self-regulation, the deep breathing, exercise. And I explained too in sort of the notes when we're doing that double dipping, right? So exercise helps in multiple ways. It's regulating, it's sensory input. The stronger he gets, the more self-esteem he's going to have. And so I layer that. I talk about, if you add music, then it has all the more power to it. He also just entered into a weights class in his electives, and I found that out after I wrote these recommendations, right? But if that's enjoyable, if he can come back home and show dad, hey, this is what I learned at weights, then that's also adding that relational component, right? That, hey, I can do this. Maybe we can do some reps together. And it doesn't have to be something where they're talking a whole lot or necessarily connecting on a deep emotional level, but it's something that they might both find enjoyable. And then whenever somebody is so sort of deplenished in their relational...
Ja se izvinjavam,
Oh,
samo imam jedno pitanje. Zanima me da li ove preporuke dajete roditeljima samo ili razgovarate i sa klijentom o tome šta bi bilo dobro za njega i šta on misli o tome. S obzirom da on ima 15 godina, da li je i on uključen u pisanju preporuka i...
So I did not have him as a part of my staffing, primarily because I wanted parents to be able to share sort of very openly whatever they were going to say, and I didn't know what they were going to say, so I didn't want T to be hurt by anything that was going to be said. But I am very specific in my interview with my clients about, tell me some things that you like, right? And making sure that I do try to create my recommendations around things that I would not see him, disagreeing with. And so it's not necessarily, oh, well, how would you feel about going and volunteering at an animal shelter? But more so I'm listening whenever he's telling me, oh, I really like being around animals, and they kind of live on a farm anyways. And so I'm hearing some of these types of things and I'm thinking, okay, that's something we can use. That's something we can use. So in that way, yes, definitely hearing his input and getting to know him and making it specific to him is something that I'm trying to do. Okay, so animal assisted therapy, I think, is something that is really a great technique to use with kiddos that don't have much of that relational connection, and that, maybe empathy or attunement is not so much there. And if not, not everyone has access to animal assisted therapy or equine therapy. So yes, can he go do some work at an animal shelter or something like that, to where he can see that other living beings have positive reactions to him, and he can see their body cues and what they mean, and when he does something that maybe an animal doesn't like, as well as, again, you're getting some of that positive reinforcement from whoever's supervising him on, hey, you're doing a really great job. Like, he really, looks forward to seeing you whenever you come in, and getting some of those positive praises, because currently he's not receiving positive praise well at home. He sort of second guesses everything that his family's telling him, right? And then really, it's important for us to break down where they're at relationally and how we need to engage with them, right? So he's really kind of at the bottom of the barrel with what he's tolerating. So we're at square one, which is parallel play with a didactic adult, right? So one-on-one, we're not wanting to do a lot of collaboration. It's very much so should be led by T. And so putting on here, right? Let's see, small doses frequently. But so yes, he likes puzzles, he likes Pokemon, he likes building, right? And so this was a discussion that we had, was that T said that he's very particular when he does his puzzles, right? Like that he has to start on the border and then he wants to go row by row down the puzzle. And I could imagine that maybe that's not the fastest way to go about doing a puzzle. But to, okay, go along with that, right? If that's what he wants to do, don't have that power struggle of, oh, there's a better way, this, that, and the other. We really want to focus on these 4 positive interactions for every 1 negative, which I know they're not meeting right now. And so figuring out ways to do that. Okay, and then this positive relational shift focus. And this is where I like, normally I wouldn't be so specific as to exactly what I would want them to do. But, you know, writing 1 positive thing or that they appreciated about T on a heart and putting it on his door until Valentine's Day, right? So that he can see that daily reminder of things that his family does appreciate about him, not just hearing that, oh, you're a liar, you're stealing things from your cousins, you're in the kitchen, you're not supposed to be, but hearing some of the positive things. Okay, sports and getting together on those types of things. Cognitive, individual therapy, a life book. So I suggest that a lot of times for my kiddos that have been adopted, but for him more so just because he was adopted really young, but he's also had so many transitions. And really what I'm hoping is that he can start to understand that his behaviors had a purpose, right? That his behaviors were that way to protect him from whatever it was that he was going through in that moment. And so that he can kind of work through that and not just see himself as this terrible kid, which is what he sees himself as right now, right? He's kind of taken on that black sheep or the outcast of the family. And we need to start shifting that into a positive identity and seeing that, you know, yes, you have lied a lot, maybe when you were in residential and you were surrounded by a lot of kids that were probably lying a lot, right? But now that you're back home, you don't have to do that so much because 1, it's hurting the relationships, right? But 2, you're safe, and we have to learn the positive way to interact with your peers and with authority and those types of things. But it just helps, I think, with identity building. And then I kind of tell them, so in each category, I give them a couple of recommendations, right? And I only put a few in the areas where he's doing pretty well. His brain is pretty strengthened in those areas. And then I put several more, obviously, in the relational category. And I did put 3 in cognitive, but I told them in my staffing, I would worry about family therapy above all else in that category, right? That's where you need to have your focus, is because there's a strong misunderstanding of what's going on together in this family. And then therapeutic web, you know, what else needs to happen? And really that network of connections for the family is what we're needing. So what are some thoughts about recommendations? What are recommendations maybe that you would have made for someone presenting as T and working with a family that's really struggling, transitioning from residential back to home?
I'm wondering from the last recommendations for like sensory integration, were the parents able to be present enough to have some awareness as to state? Because obviously, I mean, this kid's been diagnosed with bipolar disorder because he's obviously one of those mixed states we talked about. Dissociating here, up here, up here. And it's going to be one of the hardest things for this family is going to be their ability to notice which one he's at and then try to engage and direct him to engage in regulation skills to bring him closer to that window of tolerance, whether it be up or down, which is going to take more time and attention, which they're already frustrated with. So that's going to be really tough. But
Mhm.
Wondering if any of that has happened from that first one, if they're noticing what brings him up or down.
Yeah, so I think unfortunately where I'm struggling and why I'm curious if this ever happens to you all, I got so caught up and wrapped up in this, man, like he's only been home for 2 months and we're already in this cycle of only seeing the negative, and he's, for all intents and purposes, like kind of institutionalized at home, right? Like when he comes home from school, he's immediately in his room. Like that's it. He can't get his own meals. He's not allowed in the kitchen. Like his siblings or his parents have to get his meals for him because of his stealing behaviors, right? And so getting so wrapped up in that focus is where I kind of missed out on some of the other details, because I was really just feeling for that kid in that moment. But to kind of loop around to that sensory integration and being in that hyperarousal and the dissociative, he's really not acting out aggressively at all anymore. Like there is none of that. They're not seeing any of that. And so I'm not sure if that was a super proper diagnosis, or maybe he just really is getting the right cocktail right now. And that's not so much an issue, but really truly what they're actively seeing is that he will lie about anything and everything, right? Just tell non-truths, to a point where, like, for instance, he went back to school, and when you go into high school, right, what's the thing that you want more than anything? You want to create that peer group, right? You want to have that sense of belonging. And so he told the story to his case manager and to his parents of, there was this group of guys in the weights class that they had a football and they were challenging him to throw this football and hit this other kid, right? And he told them no. And so mom said in the staffing, like, I honestly don't think that happened. Like, I think he just told that story to like find a way for other people to pat him on the back, but I don't believe that happened. So it's very difficult to try to get her to praise the small things if we're denying even that those small things ever happened. So it's difficult, right? They work off of a punitive system of every time he does anything negative, it sort of goes into the same bucket, and they just add days to his grounding. And so whenever we did this in like mid-January, he reported that he was grounded out till Easter. Okay, so when you tie this back to that PowerPoint, he's kind of in learned helplessness, right? Like, how do you dig yourself out of that hole, knowing that of course he's going to make a mistake up until April, right? Like, of course there's going to be more mistakes in there. And trying to explain that if you're telling me he can't go more than 24 hours without taking something from his siblings or telling a lie of some sort, how can you expect him to go out till April then, right? Like, your system isn't matching what we know where he's at, right? So that's something I'm going to push you all a little bit. I want to hear how you would explain to a family that when a child has been traumatized, we need to change our expectations for them, because that is something that this family really struggled with, is that we have 4 other kids. How can we change our expectations and the way that we parent to tailor it to this one child whenever our other kids are going to see that it's different? So what would you all say to a family? I want to hear ideally from a couple of you. And I know it might feel uncomfortable or you might feel embarrassed, but I think it's important as we start moving towards these metric presentations that you start getting familiar with presenting some of these concepts and using some of this terminology. So any ideas? And I'm happy to say my question again if you missed it and all of that.
And Delbert, were you suggesting that putting in those suggestions that sometimes psychoeducation is something that we need to do with the parents specifically?
Yeah, so psychoeducation around awareness, psychoeducation around the fact that they really are going to have to help teeter-totter and seesaw that whole regulation issue, and what's bringing him up, what's bringing him down, and kind of being aware of that and knowing that. I know for this question, I've got parents that so hard to come around because they've got these expectations, and I'll give them homework of make a journal, and all I want in that journal is catching him doing something right. Even if it's just one thing for the whole day, I want to write something down, how I'm doing something right, even if it's super small. But it is really tough to change those expectations. And there are some cases I haven't been very successful at doing that. I've got one case that's just this what you're talking about right now is triggering me, because I've got one case that I'm not sure what to do next, because everything that we've had on the recommendations, they just don't want any part of it. They're done with him. He gets to hear that. He's the black sheep of the family. Everybody gets the scapegoat onto him. Wow, that was a real 4-H comment, wasn't it? I had a whole bunch of animals in there. So that's it really does come to that kind of psychoeducation, and the family therapy piece is going to be really helpful for you, because that positive interaction. But is the family therapist going to be able to facilitate that, or is it going to be let's just crap on this client this whole freaking session, which can be hard to rein in for some therapists. So but yeah, that's something, just to answer your question, that's something I continue to come back to, is look, they're in survival mode. They're not fully understanding exactly what's happening. They're actually, I actually used that we're getting dumber as we're getting aroused in explaining this to a parent recently. Like, he's not fully, when he's telling you he doesn't know, it's not necessarily that he's manipulating you or lying, that he may really not have known in that situation why he acted impulsively to survive. So
I see your hand, Anastasia, but I also saw Alexandra unmute for a second. So I'm going to turn it over to her real quickly, and then we'll get to you, Anastasia.
Da, htjela sam da podijelim da imam neki možda jedan sličan slučaj sa ovo što je Erika izložila, pa mi je bilo onako, odzvanjalo mi je čitavo vrijeme dok si prikazivala ovaj slučaj sa dječakom koji ima ovakve vrste problema. Moj dječak ne dolazi, nije u hraniteljskoj porodici, on je u porodici je sa svojim roditeljima, ali trenutno mama želi da izađe iz tog braka jer je godinama bila žrtva nasilja od strane oca ovoga dječaka, ali prvo što su se prijavili na terapiju jeste bilo da dječak ima problem sa regulacijom agresije i vršnjačko nasilje bilo najviše i u školi, pa i u porodici sa drugom djecom, sa djecom tetaka od drugih porodica. I onako dok si pričala, izgledalo mi je da ono što sam predložila ja za njemu da radi, da se okrene jeste kao crtanju, radu, malo uživanju sa mamom, sa tatom, da ima neko odvojeno vrijeme. Međutim, kad god sam nekako pokušala sa mamom, pošto sam jedino sa njom razgovarala, da uradim ovo što je Delbert i nagovijestio da bi trebalo da je malo raširimo opseg razmišljanja, da uradimo neku psihoedukaciju, naišla sam na negodovanje, odnosno na preispitivanje njenog majčinstva, tako da se malo i uvrijedila. I moja prva preporuka je bila da ona krene terapiju, s obzirom da od svoje traume nije mogla vidjeti ni traumu djeteta, što mogu reći da je bolje primila nego što kad sam je nešto ovako sugerisala, ako sam pokušala da to bude dosta nježnije, s obzirom kakva je situacija. Ali, na primjer, to dijete iziskuje odnos sa ocem, a to je trenutno nemoguće. Mislim, tatac ga ne vidi i to nasilje koje je prisutno u kući je nevjerovatno veliko. Znam da se terapija radi u većini slučajeva kad onako izbavimo dijete iz nasilja, da može imati nekog efekta, ali vidit ćemo, pošto mi je on jedan od klijenta s kojim sam radila ovo testiranje, Znači će mi baš možda i kad budem izlagala ovaj slučaj, vaše preporuke za ovaj slučaj. I meni je onako značajno ovo što je Erika izložila, da ću iskoristiti nekako i za svoje pisanje, ali bih voljela da čujem i vaš, tako da to sam htjela samo da obrazložim.
Thank you so much for sharing. I appreciate that.
That's a good example too of when a parent gets dysregulated. So now you have a dysregulated child and a mom who's dysregulated because that child probably reminds her of her perpetrator. So I would probably do a lot of psychoeducation to mom around co-dysregulation and how that makes situations worse, and help her figure out how she was going to regulate in order to be present with her son to help him regulate.
Mm-hmm. Okay, go ahead, Anastasia. Thank you for your patience.
No problem. So what kind of comes to mind, kind of echoing a lot of what Alexandra and Delbert has been saying, is a lot of psychoeducation. I do a bit of storytelling with parents of being like, if you remove all their abilities for activities and coping skills, you're setting them up for failure and expecting change. You're not going to get too far. Like, so a lot of times it's like, oh, if they're in their room, they can't cause trouble. I'm like, but they also can't improve because you're not giving them the tools and the skills to succeed. So it's a lot of storytelling of like scaffolding. Like if you take your child and expect them to do calculus, they're not going to be able to do it because you don't have the stepping stones to get there, but that's what your expectations are. And I have a few images that I show to parents of like what it takes to be a therapeutic parent, and like kind of shouldering some of their trauma and showing them how to cope with it and deal with it and move forward with it until they're able to handle it on their own. And with that is creating safe spaces for the child in the home. So if it's a teen, it could be kind of a corner in their room and maybe some posters or a beanbag or some of their fidgets or whatever they want in that corner. So instead of like, oh, you're being grounded to your room, it could be like, what can we do in this moment to kind of regulate together? And what can we have in your coping space that could be more helpful instead of like you're grounded and can't do anything? It can definitely be translated to be a lot more positive. And also kind of talking about the schedule as well. Like if high points are when he just wakes up, or is it right after school? I'm like being a little bit proactive about it and making sure a lot of those needs are addressed before it gets to these high points.
But so I love all of those recommendations. I love that. And I love how it's helping. It's that discipline versus punishment, right? So it's helping teach him something versus just punishing him to his room. But what about the mom that says, but I don't have to do that for my other kids, right? Like I'm not making some fun place in their room for my other kids. Why do I have to do that with T? What do we?
With that, I have a conversation with the mom is like, all your kids are in different spaces and you're expected to provide for their individual needs. Like they're not one person, they're different people. And I do some exploring with probably the mom's own life of being like, what if you were treated the same way by all your friends? How would you feel? It would probably be she'll probably have a lot of different reactions to that and probably not very appreciated. So like taking that and then applying it to T and being like, so why do you expect that to work with him?
Yeah. And I think we discussed and again, I don't know if I handled this maybe as delicately as I should have, but it came up that because she had said, right, she's adopted other kids from care. And so she said, my other kids have all been through trauma too, but I say, well, have your other kids been removed from the home for 2 years with very little contact? Well, no, right? So seeing that, like, that's a huge trauma, right? But I think she's at that point of, well, he did that to himself. And so that's that whole loop of, well, his behaviors are why he was in residential, right? Kristen, what do you have?
So I was gonna say, and sorry, there's such a bad glare behind me. I don't want to blind
okay.
people with my camera, but so I think and this is a really random thing that came to mind, but if a parent is particularly resistant to hearing some of this feedback, I think we also need to meet them where they are. And I think there could be something like a really hands-on thing, like if you have both parents, like if there's two parents sitting in the room and you have one parent put on like a thick set of gloves that are hard to maneuver and give them like kidney beans in a cup and and then the other parent gets to do it without anything on their hands. And they say, if you have 30 seconds and if you can't get 20 beans in this cup one at a time, then you're grounded. And they could see one parent can do it totally fine and the other parent couldn't because they've got all these restrictions, right? And then say, you know, T's had gloves on ever since you've had him, or T's has these things that for whatever it is, he's got these gloves on that are not allowing him to meet the expectation that your other kids are meeting. And I wonder, as you've been telling me how hard it's been for him to meet these expectations, like what could you do to help him have different expectations that he could meet and start from there and build from there. But I think with some of the parents who may be a little bit kind of stuck in that narrative of the other kids can do it, I think sometimes it takes like doing something physical to have them simulate an experience in some way, even though it's, you know, not the same. I just, I don't know. I don't know if I explained that clearly, but
yeah, no, absolutely. And I love that that's the visual, right? Like we love this metric because it's the visual and it's so easy for the team or the family or whoever you're working with to see that there are impairments, right? That this child is doing the best that they can with what they have, essentially. And how far the family accepts that sometimes is different, right? But I appreciate very much that visual and that experience of really showing them that they truly are at a disadvantage. So then the next barrier that we oftentimes see is, what about the family that then says, well, I've done all of those recommendations, right? I've done all of those and they haven't worked. What's the next step? See, Kristen.
I think some of it
recently.
is, sorry, I was going to say some of it is exploring how consistently those things have been done. And then maybe also saying, well, maybe it didn't work, you know, wherever he was at 2 years ago, but it may be worth trying again now that he has had some growth. But sorry, I think I interrupted somebody else. Sorry.
No, yeah, go ahead. Sorry, thank you. Go ahead, Anastasia.
So I recently heard this from a client, actually, like, I did everything you said for 2 weeks and nothing's changed. I was like, oh, 2 weeks is great, but we need more than 2 weeks. So like, what's your definition of like, I've done everything? And for your point, Christian, is like, how long did you do it? Was it consistent? You're not going to have, like, going back to the expectations piece, being like, if you're taught something once, you do it one time, it's not going to be drastically changed.
Yeah.
It's the incremental steps, kind of altering those expectations.
Yeah. Melanie, we'll hear from you and then we'll kind of close up our comments here.
I was just going to add on to what Anastasia said. I think that makes a lot of sense. Behavior takes time. I know it takes at least 4 to 6 weeks for us to see a change in behavior, and often it gets worse before it gets better. But also, just to make it in a way that parents might understand, you can think of it in a way of like trying to lose weight. Like if you try to lose weight for about 2 weeks, how great are your results? Like generally they're not so great, at least in my case. But you have to do those consistent things over time. And it is a question of consistent approach as well as time. It's not just a quick thing.
Yeah, yeah. So excuse me, sorry. Absolutely. And Kristen, I said exactly what you said as far as I was lucky enough in this instance to have the 2 brain maps, right? And so I was able to show her, look, you can see his brain does not look the same as what it used to have, right? And I didn't say this, but he's only been home for 2 months at the time, right? So during that whole time he was in residential, I know you weren't trying any interventions. And so assuming that you're either only talking about since he's been home or before that, a lot has changed. And so I think whenever you get those parents that are really stuck there, it has more to do about their own work than really the state of the child, right? And so really then pushing on who are you processing with, right? Because especially in her circumstance where you have dad saying, I'm done, I'm out, well, then it's all falling on her, right? And how quickly she's going to burn out whenever she doesn't have anyone else to kind of hit the pause button to. And so I think
another way that I sometimes talk with people when they're struggling with nothing's changing is I'll bring up, okay, well, he's been using these behaviors for survival for 15 years. Mm-hmm. It's going to take that long, or obviously more incremental stages for him to turn that around and have benefits from trying to do things differently.
Mm-hmm. Mm-hmm. And I think we can use sort of the states of arousal for our parents too, to help them figure out where they are in their understanding and what they're dealing with. Because I think it was hard for her to see, right? She was sort of in that lowered IQ, if you will, Delbert, right? And not seeing the full range of time because she's just been so overwhelmed, because that's just one kiddo, right? I mean, it's, as someone that has 4 kiddos, I know that kind of all of your kids are struggling on different levels and needing different things. It's not like she can focus all of her attention on that one child. And so I think it's definitely difficult, but we have to try to, like you said, put that knowledge on the parent, but also, you know, how can we help support you, right? So thank you guys so much for all of your engagement today. I think that we had some really incredible conversations, and I hope that you all enjoyed them as well and learned from them. I think Andrew's kind of going to wrap us up a little bit with just what our expectations will be moving forward. And then, yeah, thank you all so much.
Sweet. Yeah. And great conversation. That's what we love about these NM meetings, are wise minds that have a little bit different maybe viewpoint on how to work through problems, sharing ideas and working together. And that's a great thing about the study group, is we can kind of bounce ideas off each other and learn and grow, rather than just learn the concepts. Now we can learn how to implement them. So get ready for your stress response systems to be activated. Next module, module 5, there will be individuals who will be asked to present on one of their metrics. And so you have 2 metrics that will be due. And one is, you know, just a regular client, you know, a client that has some challenges and issues that you're working on. And then another metric is what they call the ER metric, which part A and B, you just rate the number 7 for everything. And then part C, you give the current functioning, and part D, the current relational health. So you can choose whichever metric and client you want to present, but we will have 3 breakout groups. And let me share my screen real quick. I hope people don't mind I share emails. I think those are already on there. So Angela is taking a couple of different individuals, Erica, Delbert, Anastasia, and Susan, and we will put you guys in a group for one of you 4 will present, and Angela will reach out to you 4 individually. And hopefully, if this has happened, or maybe it hasn't happened yet, just to kind of check in with everybody individually to see how they're doing, check up on their modules. And this isn't like, to point fingers or to get you to hurry up. It's like, what else do you need so you can be successful in this training, right? Angie has the group from Montenegro. And so they'll probably just stay on the call instead of putting them in a group, because we also have to have Danilo on there. And I'm not sure how the translator will work going into a group. So we're going to problem solve or problem shoot that before we get on. And then Erica has Amanda, Teresa, Mackenzie, Kristen, and Melanie. And our hope is just that with this, the trainers reaching out, that they give you a little bit of one-on-one time to maybe ask some questions or check in. And if you're really struggling with getting your metrics done, or you don't understand something, you have an opportunity to share and maybe work through that. But remember, in order for you to be certified, you have to be able to speak to the metric. And so this is just the first time. It won't be the last time. You guys will have other opportunities to present. And so we don't expect you to go the whole hour during the study call, not the study call, the presentation time. We'll talk a little bit more about what that's going to look like in our trainers group, and we'll send out more information in an email. But kind of be prepared to talk about 15 minutes on a client, just a little bit about what the client's history is, and then how you did the metric. And what we're wanting to see is how you speak towards a part, like how you speak towards the scores, or maybe if you want to talk about the results, and go from there.
Yeah, so of the 15 minutes, a very brief period should be on the abstract, right? We want you to focus on the metric part of it. So
yeah,
just a
we're
few
not going to
highlights.
do any like case consultation feedback right now. We just want to get you guys comfortable with talking about the metric, like the brainstem concepts or the diencephalon concepts and stuff like that. And some of you may already be using it in your work, which is great. And so this is just a chance for you to get some feedback from us, and encourage you to talk about those concepts in a way that you start mastering them. And if you fail, then you have to go back to module 1. I'm just kidding. That's a joke. No, everybody's gonna pass. We're just gonna encourage everybody to continue to grow. So thanks for hopping on this Zoom link. I must not have put the translator toggle switch on the last one. And so I'll be sure to do that. And if you guys have any questions, make sure you reach out to one of the trainers, turn in those signed module sheets, and keep doing great work. Thanks for your time today. We'll see you.
Thank you.
Andrew, I was going to ask you a question really quick.
Who said that? Melanie? Yes.
Melanie did. I noticed in the last session, I wasn't able to be there in person, but you had talked about a document to help kind of facilitate the questions through the metric. And I was wondering if you could send that to me, because that's been the hardest thing for me, is just trying to ask the questions in a way that's more concise and not just takes really long.
We have a number of documents that we use. The child and adolescent history form is the best one, and it's on the NMT website.
I did see that one.
I mean, it literally says perinatal, interuterine, perinatal, early childhood, right? And it's color coded. So if you have access to a color printer and you can print that out, I actually have a write-on PDF-able. Is that a word? I have a PDF file that you can put on, and sometimes I'll email that to a parent and have a parent send it back.
Okay.
Is that something you'd be interested in?
Yes, please.
Okay.
Okay.
See if I can find that. And as far as anything else, just ask everybody else. I mean, we'll give you and share any tools that we have, but typically it's up to the individual on what works and is most comfortable with them.
Gotcha. I noticed a lot of family history questions, obviously, on the child history questionnaire, and often the kids I'm working with are adopted, and a lot of those questions are just, you know, they don't know.
Yeah, so I'll attach another file that we use about current functioning that just has some questions, but typically it's just, I just print out part C.
Yeah.
And just, make little notes on that. So I'll send that to you too.
Okay. Awesome. Thank you. All
Uh-huh.
right, bye.
Bye. Andrew, did I miss, are we just emailing somebody in our group randomly? Did you say, did I zone out?
That's what I would do. If I were you guys, I'd send out an email individually and then ask them, hey, how you doing? Do you want to set up a call if you have access to a Zoom or a Teams meeting, and set that up for just a couple minutes? You know, don't have to spend an hour with them. It's not like supervision. But I've found that when you train people in a group like this, you'll have 2 or 3 that won't speak. It's just
Mhm.
not their, you know, forte, but they got lots of questions. And so that's just giving, as a trainer, it's giving someone another avenue to reach out. And most of the time it's just email. Hey, just checking in on you. I only have module 1. You know, can you send the rest of those in when you get done? And go from there.
Yeah. Okay. Yeah. I mean, I think we've all sent out our individual emails in that regard, and just sort of like a progress report of things. But okay. So just setting up a little brief virtual check-in before they present.
Yeah. And I don't know, was Sarah out today? I don't even remember.
Yeah. Her son had surgery today.
Oh, that's right. I probably should know. I do know that.
Morning,
but
Andrew.
It's been a crazy day. So the same thing's going to go for you guys. I think I asked Sarah how to divvy you 3 up, and we just haven't done it, but we'll be reaching out to you guys individually, talking about that. And I have like a little rating sheet that we use to kind of give you guys some feedback on your presentations and stuff, just to give you some ideas and feedback. And I think you guys do great. I mean, obviously there's no negative stuff, but just to kind of let you know how we hear things and see things from this end. So
Okay. Sounds good.
We'll figure out how that's going to move going forward.
Okie dokie.
All right, I got to hop in the car and drive to Lebanon. Got an hour to get there in 50 minutes.
Oh, okay. See ya.
See ya.
Bye.
All right.